The moment a bullet finds its target or a piece of shrapnel tears through flesh, a clock starts. It has no display, makes no sound. But every combat medic who has ever run toward a fallen soldier under fire knows it is running. The minutes between the wound and the first competent hands reaching it determine more about whether a man lives or dies than almost anything else in the entire chain of military medicine. That chain, stretching from the instant of wounding through field treatment, evacuation, forward surgery, and eventually definitive hospital care, is one of the most consequential achievements in American military history. It was built slowly, at enormous cost, through a process of learning that required first watching men die from wounds that could have been survivable, and then building the systems, training the people, and carrying the equipment that would let fewer of them die the next time. Understanding how American soldiers treated deadly wounds requires understanding what those wounds actually are, what they do to a human body, and why so many of them are survivable with the right intervention at the right moment. The wounds that killed soldiers in American wars fall into a relatively small number of categories, and each category has a specific physiological logic that determines what kind of treatment can interrupt the process that would otherwise lead to death. Massive bleeding is the most immediate killer. A large blood vessel severed by a bullet or shell fragment can drain the body's entire blood supply in minutes. And a man who has lost enough blood to prevent his heart from maintaining adequate circulation will lose consciousness, then organ function, then life, in a sequence that is rapid and that becomes irreversible well before the blood is entirely gone. Tension pneumothorax, a condition in which air accumulates in the chest cavity outside the lung and compresses the heart until it cannot beat effectively, kills almost as quickly. Airway obstruction, whether from blood, vomit, swelling, or the position of an unconscious casualty's own anatomy, kills in minutes. These three categories, massive bleeding, chest injuries, and airway problems, accounted for the vast majority of potentially preventable combat deaths across American military history. And the story of combat medicine is largely the story of learning to address each of them faster and better. Letterman's contribution was organizational rather than medical in the narrow sense. He understood that the problem of combat casualties was not just a surgical problem, but a logistical one. That the best surgeon in the world was useless to a man bleeding to death on a battlefield if no one had a system for getting that man to the surgeon in time. The tiered evacuation system he developed, which moved casualties from the point of wounding through increasingly capable levels of care, became the conceptual foundation for every combat medical system the American military would build in subsequent wars. The specific tools and treatments would change dramatically. The underlying logic of organized, tiered evacuation toward escalating levels of care would remain constant. The First World War introduced American medical personnel to wounds and wound volumes that exceeded anything the Civil War had produced, and to infection as a killer that rivaled the initial wound itself. Shell fragments, which became the dominant wounding mechanism of industrial warfare in a way that bullets alone had never been, created wounds with characteristics that differed significantly from bullet wounds. Shell fragments were irregular in shape, tumbled through the air unpredictably, carried clothing and dirt and other material into wounds on impact, and created tissue damage patterns that were difficult to clean and close in ways that prevented infection. The great killer of the First World War after the initial wound was sepsis, the body-wide infection that resulted from bacteria introduced through the wound and allowed to proliferate in damaged tissue that the immune system could not effectively defend. Surgeons who mastered the debridement of wounds, the aggressive surgical removal of damaged and contaminated tissue, saved lives that a less thorough approach would have lost. Those who relied on simple cleaning and closure found their patients dying of infections that seemed to come from nowhere. The lesson about infection shaped military medical practice through the Second World War in ways that are difficult to overstate. Sulfa powder, a sulfonamide antibiotic that became available in the late 1930s, was issued to American soldiers specifically to be applied directly into wounds immediately after they occurred, before any other treatment, as a way of suppressing bacterial growth during the minutes and hours before a medic or surgeon could provide more complete care. American soldiers in the Second World War were trained to tear open the sulfa packet in their first aid kit and pour it into a wound before applying a bandage. And this simple action, costing perhaps 30 seconds and requiring no medical training to execute, saved lives that would otherwise have been lost to infection in the days following treatment. It was one of the earliest examples of a principle that would become central to American combat medical thinking. Give the individual soldier and the closest available person tools to begin treatment immediately, before any trained medical personnel arrive. The M1942 first aid packet carried by American soldiers in the Second World War was a compact, waterproof package containing a bandage, sulfa powder, and morphine in a syrette, a small injectable tube that a wounded man or his buddy could use to administer pain relief. It was not sophisticated by later standards. It was designed around the recognition that in the minutes after wounding, when a man was most vulnerable and trained medical help was furthest away, the first treatment would almost always be self-treatment or buddy treatment, not care from someone with medical training. The equipment issued to the individual soldier reflected this reality. The bandage stopped external bleeding. The sulfa reduced infection risk. The morphine made the pain manageable enough that a wounded man could participate in his own evacuation rather than becoming an additional burden on his unit. Combat medics, the men who carried more advanced equipment and ran toward the sound of fire when soldiers went down, were the central figures in American battlefield medicine in the Second World War. They were not physicians and not surgeons. They were trained to perform a specific set of interventions under fire that would keep a man alive long enough to reach someone with more capability, stopping bleeding, clearing airways, treating shock, packaging wounds for transport, managing the walking wounded in ways that preserved their ability to move under their own power. These were the skills that medics trained repeatedly and performed under conditions that were by definition the worst possible circumstances for careful, precise medical work. The specific techniques for controlling massive bleeding available to Second World War medics were limited compared to what later generations would have. But they were not ineffective. Pressure bandages applied directly over wounds and held firm could control bleeding from many wounds that were not directly over major blood vessels. Tourniquets, strips of material that could be tightened around a limb above a wound to cut off blood flow entirely, were available, but were used with a caution that later medical experience would call into question. The medical thinking of the Second World War era viewed the tourniquet as a last resort, a tool that controlled bleeding at the cost of depriving the limb of circulation and risking tissue death if left in place too long. Medics were trained to prefer pressure over tourniquet when pressure could control the bleeding, and to apply tourniquets only when bleeding was clearly uncontrollable by other means. This caution about tourniquets, grounded in genuine concern about limb loss from ischemia, contributed to deaths from extremity wounds that later analysis would show were preventable. The reassessment of tourniquet use that became one of the defining lessons of American combat medicine in the early 21st century had its roots in data collected from every previous conflict showing that soldiers died from extremity bleeding. That tourniquets applied earlier would have controlled, but in the Second World War, the balance of evidence as understood at the time pointed toward restraint, and medics operated accordingly. Plasma and whole blood represented one of the most significant medical advances of the Second World War in terms of battlefield survivability. Hemorrhagic shock, the physiological crisis that results when blood loss reduces circulation below the level needed to sustain organ function, had killed soldiers in previous wars who survived their initial wounds only to die from the body's inability to maintain perfusion of vital organs. The development of dried plasma that could be reconstituted with sterile water and administered intravenously gave medics and forward surgical teams a tool to restore circulating volume, buying time for the definitive surgical repair that would ultimately control the source of bleeding. Plasma didn't replace blood, and the limitations of plasma in severe shock were understood even then. But it was a major advance over the saline solutions and other volume expanders previously available. The forward surgical teams that operated close enough to the front lines to provide early surgery played a critical role in the survival of wounds that would have been fatal if surgery had to wait for evacuation to a rear area hospital. The Mobile Army Surgical Hospital concept, which became famous through the Korean War and the cultural phenomenon that followed it, had its roots in the Second World War's experience with forward surgery. The principle was straightforward. The earlier a surgeon could control internal bleeding, repair a damaged bowel, remove shell fragments from a body cavity, or perform the other interventions that stopped the ongoing physiological damage from a severe wound, the more likely the patient was to survive. Keeping surgical capability as far forward as the tactical situation would allow, accepting the risks that came with operating close to artillery range and air attack, saved lives that the alternative approach of waiting for evacuation to safe surgical facilities would have lost. Chest wounds presented specific and urgent challenges that Second World War medical practice addressed with varying degrees of success. An open chest wound, one in which the chest wall was penetrated and the seal between the chest cavity and the outside air was broken, allowed air to enter with each breath, progressively collapsing the lung on the affected side and eventually compressing the mediastinum, the central structures of the chest, including the heart and great vessels, in ways that could be rapidly fatal. The treatment, sealing the wound with an airtight dressing that prevented further air entry while allowing air that had already accumulated to escape, was within the capability of a trained medic and could prevent death from what would otherwise have been a survivable wound. Medics in the Second World War carried materials that could be improvised into chest seals, including the waterproof wrapper from the first aid packet itself, and training emphasized the recognition and treatment of open chest wounds as one of the highest priority interventions. The psychological dimension of wound treatment under fire is something that after-action reports and medical manuals don't fully capture, but that every medic who has performed it understands as inseparable from the physical work. Working on a severely wounded man who is conscious and afraid requires managing his fear as much as his physiology. Maintaining a calm that reassures the patient that someone competent is in control even when the situation is objectively dire. And communicating with a confidence that is partly genuine and partly performed because the patient's belief that he is going to be all right has direct consequences for his physiological response to shock. The adrenaline response of a terrified man in severe pain places additional demands on a cardiovascular system already compromised by blood loss. A medic who can reduce that terror through voice, touch, and the visible performance of competent treatment is doing something that has direct physiological effects, not just psychological ones. Pain management in the Second World War was crude by later standards, but represented a genuine commitment to the humanity of the wounded soldier that wasn't always present in earlier conflicts. The morphine syrette in the standard first aid packet was designed to be used on the battlefield by anyone, medic or fellow soldier, and the convention of pinning the used syrette to the casualty's collar so that subsequent medical personnel would know he had received morphine. And when was a simple and effective way of preventing accidental overdose during handoffs between levels of care? Morphine reduces pain, but also reduces respiratory drive, and a dose that was appropriate for a conscious, breathing casualty could be dangerous for one whose condition had changed during evacuation. The visible record on the collar addressed this risk in the simplest possible way. The combat medic who ran toward a fallen soldier in the jungles of Vietnam or the frozen ridges of Korea was carrying equipment and knowledge that was significantly better than what his counterpart in the Second World War had available, but he was performing fundamentally the same function: buying time. Every intervention that a medic made in the field was time purchased for the surgeon waiting further back in the chain, and every minute that time could be extended without the casualty's condition deteriorating beyond the point of surgical repair was a minute that might be the difference between a man who came home and one who didn't. The tools changed. The clock kept running. The medic kept running toward it. The history of American combat wound treatment is ultimately a history of compressing that clock, of reducing the time between wounding and effective intervention, of expanding what effective intervention means and who can provide it, and of building a system robust enough to function under conditions of violence and chaos that would overwhelm any system not specifically designed for them. It is a history written in the survival of men who, in earlier wars or without the systems their own generation built, would not have survived. Every improvement in tourniquet technique, every advance in blood replacement, every innovation in forward surgery, every improvement in evacuation speed represents lives that exist because someone, somewhere, looked at who was dying and why, and decided that the answer was not acceptable.